All my colleagues. Today I'll be presenting student CPC from the Department of Neurosurgery. So I'll be presenting case of Mrs. A. She's a 38-year-old female, managed under Unit 1 in Neurosurgery. Day of admission was 11/9/22. Day of surgery was 27/9/22, and day of discharge was 8/10/22. So she came to our site with a chief complaint of headache on and off for last 2 years. This was her only complaint. In history of present illness, patient was apparently well 2 years back when she developed headache, which was insidious in onset, gradually progressive, relieved on medication. For past 1 year, her headache increased in intensity from moderate to severe and was associated with vomiting. Patient also started to have fainting episodes, for which she consulted a private hospital in Dehradun, evaluated as a pineal region tumor with obstructed hydrocephalus, and underwent right-sided medium pressure VP shunt on 26/11/2021. Following surgery, her headache subsided. Patient came to our site for definitive surgery with again developing some complaints of headache. Patient do not have any history of seizures, weakness, or vision loss. Patient was on phenobarbital 30 mg OD. On general examination, patient was conscious, alert, oriented to time, place, and person. Pulse rate was 88 beats per minute. BP was 120/70 mm of mercury. Respiratory 18 per minute. She was afebrile. Respiratory, CVS, and abdominal was within normal limits. Pupils were bilaterally equal, normal in size. Power was 5/5 in all 4 limbs. Sensory system was normal, and there was no cerebellar signs. Examination of cranial nerves. Visual acuity, right side was 6/9, left was 6/6. No field deficit, no nystagmus. Pupils were bilateral normal reaction. Fundus was normal, no papilledema. 3, 4, and 6, no ptosis, no ophthalmos. Extraocular movements were present in all directions, no restrictions, no nystagmus. Patient do not have any temporal fossa hollowing, no deviation of jaw in opening jaw, bilateral equal bulge in masseter over teeth clenching, power of opening of mouth was normal. Fine touch was normal bilaterally. Direct and consensual corneal reflex and jaw reflex were absent. Cranial 7 examination was normal, 8th was normal, Weber's was centralized, air conduction was more than bone conduction. On both sides. Cranial 9, 10th, there was no difficulty in deglutition, no nasal intonation, no change in voice. Uvula was central, palatal arch symmetrical, gag reflex bilateral present. Bilateral equal bulk of both sternocleidomastoid, trapezius, shoulder shrugging, equal resistance, and was normal. She was also able to rotate head against resistance. There was no deviation of tongue over protrusion, no fasciculation of tongue at rest. Her hematological parameters were also normal, and CSF marker alpha protoprotein was 0.24, which was well within range, and SCE was 0.32, which was well within range. On imaging of the patient, we find a well-defined ovoid mass, which was iso-intense on T1 and was heterogeneously hyper-intense on T2, with avid enhancement, avid contrast enhancement. The lesion was anteriorly compressing the third ventricle, and superiorly it was up to splenium. So we planned definitive surgery for the patient. So little brief about the lesions in this region. So this region is a region of third ventricle and pineal region. So our approach is basically depends on the location exactly. So here I have tried to show if the location is at foramen of Monroe. So anterior transcallosal, transforaminal endoscopic approaches are favored in these cases. If approach is type B, which is the anterior of the third ventricle, then lateral subfrontal or pterygoidal approaches can be taken. But like in our case, the lesion was at location C in the pineal region or posterior third ventricle. In these cases, two approaches are basically well defined, which are occipital transcentorial or infratentorial supracerebellar. So we followed the supracerebellar infratentorial. So a little bit about the before deciding any of the approach, we have to consider these things about all both of these approaches. A supracerebellar infratentorial approach can be done in a sitting or concorde position. Complications which we fear or which we should look for in sitting position is air embolism. Next are hemorrhage, pupillary abnormalities are common while taking this approach, and venous occlusion. If we take occipital transtentorial approach, visual field deficit are common due to traction on occipital lobes or disconnection syndrome. With the chances of splenium injury, or there is also limited exposure to the tumor extended to contralateral side. Also, there is difficulty to see contralateral vein of Rosenthal's. Combined approach may be used when the extension of tumor is in both infratentorial and supratentorial compartment. But the things which we look for while taking this approach is brain edema and venous infarcts is common if dominant sinus is taken, because in this combined approach we have to take sinus also. So after planning, we plan the patient and we operate this patient in sitting position. After position, this was the final positioning. After positioning of the patient, dura was incised in conlinear fashion, reflected and separatedly, and anchored with ridge fascia. Bridging veins over the dorsal surface of cerebellum from the sinus was sacrificed. Arachnoid adhesions between the cerebellum and tentorium was dissected. Cerebellum was pushed down due to gravity, and also position of head allowed sufficient depression of the cerebellum. Arachnoid of the parotid germinal region was thickened and was dissected. Precentral cerebellar vein was seen extending from the edge of vermis to vein of Galen was seen and skeletonized. Intraoperatively, in our case, there was an episode of air embolism where patient has a sudden onset hypertension and tachycardia and a raise in EtCO2, which was managed by anesthesia team, and the procedure was started again. So after the midline skin incision, burr holes were made on both sides of the sinus, and craniotomy was done. The exposure which we wanted was to look for the exposure of the superior sagittal sinus and the transverse sinus, and dural incision was given in convenient fashion, and the cerebellar hemisphere lobes were pushed down by the gravity, and tentorium was retracted. After peeling and dissecting the arachnoid, we reached the tumor which was soft, suckable, yellow colored, highly vascular with well-defined margin, which was seen in pineal gland region. Anterior, lateral, and inferior aspect of tumor was excised. The only thin sheet of tumor was left, which was present beneath the precentral cerebellar vein. So precentral cerebellar vein was preserved. Bilateral foramen of Monro was identified. After the excision and procedure, dura was closed in watertight fashion using periosteal patch. Intraoperatively, frozen section was sent, which was suggestive of grade 1 or 2 neoplasm. Post-op NCCT had suggested for complete removal, gross total excision of the tumor. There was no tumor cavity, hematoma or residual, which was suggestive. Finally, we will be having a MRI after 3 months. So, course during the hospital stay of this patient was, she was a 38-year-old female with complaint of headache and episodes of syncope, was admitted, evaluated, and underwent occipital and suboccipital craniotomy with supracerebellar infratemporal approach with the near total excision of the tumor on 27/9/22 for pineal region tumor with extension to third ventricle. She was a case of post-right MPVP shunt. Patient was not extubated in post-op immediately and shifted to neuro ICU. She was extubated next day, POD2. Rest of the course during the hospital stay was uneventful. Patient was discharged in satisfactory condition. In post-op period, we look for the complications which were expected in these surgeries. Fortunately, in our case, patient has no restriction of EOM, extraocular movements. She has movement in all gaze. Also, there was no neurological deficit in the patient. Final pathology of the patient was pineocytoma. Pineocytomas, in brief, are WHO grade 1 tumors that make up 15 to 30% of penile parenchymal tumors. Peak incidence is between 25 to 35 years of the age. Presenting symptoms are related to increased intracranial pressure like headache, visual disturbances or hypothalamic dysfunction. Grossly, they are well demarcated lesions which may have areas of cystic degeneration or focal necrosis. Histologically, they are similar to normal pineal glands, well differentiated cells but hypercellular. Fibrovascular stroma highlights expansive lobules of tumor cells with uniform round nuclei. They have pineocytomatous rosettes. They also may have features of neuronal differentiations. They are usually non-infiltrative, rarely mitotic figures, no necrosis, no or minimal ATPR. Pineocytomas have excellent prognosis with 5-year survival rate of about 85%. So, PN parenchymal tumors show immunoreactivity to a variety of neuroendocrine markers such as neurofilament, synaptophysin, like shown here, neuron-specific enolase, chromogranin, or CD56. Also, pineocytomas, as I told, have low mitotic rates and low Ki67 labeling index. Thanks for your kind attention.